Good morning, everyone. Myself, Dr. Olivia Thomas, second year neurology resident, presenting today's first journal. The session is moderated by Professor Dr. Ashalatha. Journal for today is comparative analysis of new-onset refractory status epilepticus in adult and pediatric patients, immunotherapy timing and functional outcomes by Halavani et al., published in the Journal of Neurology in April 2025. A brief introduction about NORS. NORS, or New Onset Refractory Status Epilepticus. The term was initially proposed by Wilder Smith in 2005, where he studied 7 individuals of NORS. And later, the incidence of refractory status epilepticus was found to be 3 in 100,000 population, and out of which 20% was found to be of NORS. So 0.6 in 100,000 was the average incidence of NORS in the world. And after various case reviews, case studies and case series, the ILA in 2018 gave a definition for NORS, where it has defined NORS as a clinical presentation in a patient without non-active epilepsy or history of other relevant neurological conditions with a new onset of refractory status epilepticus without an event of acute or active structural, toxic or metabolic cause, but including patients with viral or autoimmune diseases. NORS, therefore, they have defined NORS as a clinical presentation rather than a diagnosis. And ILA 2018 has classified fires as a subheading under the NORS. And fires, they have included all ages. And it's defined as a subcategory of NORS that requires a prior febrile infection with fever starting between 2 weeks and 24 hours prior to the onset of refractory status epilepticus, with or without fever at onset of status epilepticus. Why, even though similar entities, why they are given different names and different classifications? It's because NORS, it points towards the etiology. NORS, in most cases, points to an immune etiology, whereas fires, in some cases, it points towards infection as well as immune etiologies. In 2013, Gaspard has extensively studied 130 cases of NORS and has found out possible etiologies of NORS, out of which 48% of the population, he could find out a cause. In 52% of the population, he could not find a cause and named them cryptogenic. Among the etiologies that he had found out, they included paraneoplastic autoimmune causes of anti-NMD, anti-VGKC, cerebral lupus, anti-GAT65, and paraneoplastic causes like anti-CRMP5, anti-RO, anti-WHO, infection-related ones like associated with Epstein-Barr virus, varicella zoster, CMV, West Nile, mycoplasma, syphilis, toxoplasma gondii, and others like leptomeningeal carcinomatosis and Creutzfeldt-Jakob disease. And in 2022, Wikstrom et al. Proposed an international consensus for the recommendation for evaluation as well as management of NORS patient, briefing in detail for general information. And they have proposed a workup for patients of NORS, which includes a standard workup and a continued workup in selective cases. Standard workup, which has to be administered in all patients, include an MRI brain with gadolinium contrast, EEG, blood and serum analysis, which includes basic blood investigations, autoimmune panel, SLE panel, MOG, GAT65, anti-thyroid, paraneoplastic panel, ANA, ANCA, serum cytokines, immunoglobulins, as well as DNA for genetic testing if indicated in case of suspected mitochondrial disorders, and viral serology, including HIV, HSV, enterovirus, SARS-CoV virus, bacterial serology in indicated cases to rule out syphilis, chlamydia pneumonia, Bartonella Hensley, mycoplasma pneumonia, Coxiella burnetii, Shigella psittaci. and blood cultures for bacteria and fungi. And CSF analysis include basic protein glucose, lactate, IgG albumin ratio, immunoelectrophoresis, cytokines is if available, and CSF autoimmune panel as well. Then CSF PCR for to rule out common viral and bacterial causes of meningoencephalitis, and toxicology screening. In selected cases, they have to undergo continued workup. Example, in immunocompromised patients, they have to be worked up for uh, uh, Cryptococcus species, Histoplasma, Toxoplasma gondii, JC virus, HHV6, etc. And if the patient has risk of exposure to specific pathogens associated with encephalitis, we have to do specific IgG panel or PCR cultures that are specific to them. And if there is a suspicion of paraneoplastic encephalitis, whole body PET CT or pelvic testicular ultrasound or pelvic MRI is indicated. If there is a suspicion of inborn error of metabolism or genetic disorders, including mitochondrial disorders, we can proceed with amino acid analysis, TMS, urine amino acids, plasma and CSF lactate pyruvate, metabolic screening, as well as MR spectroscopy and genetic analysis, and even whole exome or mitochondrial genome sequencing if indicated. If there is a cryptogenic lesion found out in MRA, we can proceed with brain biopsy. This is the general guideline that they have proposed for the management of NORS. They have given importance for timing of the initiation of treatment as well as continuation of immunotherapies, so that the people have better outcomes. And the initial treatment, that is within 48 hours, patient has to be treated similar to any refractory status epilepticus by the local guidelines by anti-epileptics and anesthetic drugs in order to control the seizures. And we have to rule out any possible infections and administer antibiotics, antiviral or antifungal if necessary. And all the acute diagnostic workup results after being available within 48 to 72 hours. If the etiology is identified, we can manage accordingly. But within 72 hours, patient has to be started on initial immune therapies. That is IV methylprednisolone or IV steroids or IVIG, and therapy or therapeutic plasma exchange, unless that it should not delay subsequent steps. If response is incomplete to this first-line immunotherapies, within 7 days, patient has to be initiated on ketogenic diet as well, either oral or parenteral administration, as well as within 7 days to initiate on second-line immunotherapies. If within 7 days, if we are able to find out an antibody or there is a suspicion of an antibody-mediated disease, we can proceed with IV rituximab. If it is in the other case, such as in case of cryptogenic nodes, or if the antibodies was not available within 1 week, we can proceed with IL-1 receptor antagonists like IV anakinra or IL-6 antagonists like IV tocilizumab. Even in cases where we have tried rituximab, anakinra or tocilizumab can be added sequentially if the rituximab is ineffective. And keeping this in background, coming to our journal, it investigated the impact of immunotherapy on the ICU duration and functional outcome, and they have compared between adults and pediatric cohorts. It was a retrospective cohort study, and the study population were adult and pediatric patients with NORS admitted in McGill University Healthcare Center, Neurology ICU, and Pediatric ICU, and they were studied in between January 2013 and July 2023. And the subjects were included based on the definition of NORS that I've already specified, and the cases included the metabolic, in cases where metabolic, toxic, or structural etiologies were found out, or other diagnosed cases of epilepsy. And the data was collected from electronic medical record systems, including the baseline demographics, including age and sex, clinical features, including seizure onset type, presence of fever or prior psychiatric symptoms, diagnostic testings, basic diagnostic tests, MRI, EEG, autoantibodies, treatment received, anti-epileptics, anesthetics, immune therapies, or additional investigations, and or interventions, and timing of initiation of first line and second line immunotherapy, whether they needed any long-term ASMs, and what was the length of ICU stay in each of the patients. And they planned the following correlation analysis. They planned to correlate between MRS score and the early initiation of first line therapy, MRS score discharge and early initiation of first line immunotherapy, length of stay in ICU and timing from admission to initiation of first line immunotherapies, and MR score at discharge and timing of second line immunotherapy, and length of stay in ICU from admission to initiation of second line immunological treatments. And statistical analysis was done using SPSS software, and Pearson test was used to analyze between the groups. P-values less than 0.05 were considered statistically significant. And they estimated that at least 10 adult patients and 10 pediatric patients were needed to conduct a meaningful statistical analysis. And the results include the basic demographic, the total population that they could collect was 15, of which 10 were adults and 5 5 belonged to pediatric groups. And out of 15, 12 were classified under NORS, and 3 were FIRES. And FIRES were all the 3 were pediatric group. And 50% of the adult patients had a pre-existing medical condition, whereas only 25% of the pediatric group had a pre-existing medical condition. Prior psychobehavioral symptoms were present in 40% of the adult population. Regarding seizure characteristics, 60% of the overall population had focal seizures. Coming to laboratory and instrumental results, that is, the autoantibodies were found in CSF, that is, anti-NMDA was positive in 3 patients in CSF. Anti-Hu was positive in serum in 1 of the adult patients. Anti-thyroid peroxidase antibody was positive in 1 of the pediatric group patient. And 1 of the adult group patient had elevated IL-26 and IL-18 levels. So a total of 33% of them had an antibody positivity in CSF or serum. And so a total of 7 adults and 3 pediatric patients were diagnosed as cryptogenic NORS, as no etiologies were found out in them, or no antibodies were demonstrable in them. And the clinical outcomes were measured. That is, they measured the timing from admission to first-line immunotherapies. That is, first-line immunotherapies were given within 7 days in 80% of the pediatric population and 70% of the adult population. And second-line immunotherapies were given within 7 days in 25% population and 20% adult population. In the adult group, 3% expired, whereas pediatric group, there were no deaths. And all patients required multiple anti-seizure medications and multiple anesthetics, with medians being 4.5 anti-seizure medications and 3 anesthetics in the adult group, 6 anti-seizure medications and 3 anesthetic agents in pediatric group, respectively. And first-line immunological treatment used were included IV steroids, IVIG, and plasmapheresis. And 93% patients received IVIG or IV steroids. 66% of patients underwent plasma exchange. And the median time from admission to initiation of first-line immunological treatment was 3.2 days for adult group and 3.8 for pediatric group, whereas it was 8.62 for adult group to start on second-line immunosuppressive therapy, and 38.3 in the pediatric group to start on second-line immunosuppressive therapies. And in the current study, the second-line immunotherapies used were rituximab, 6-cyclophosphamide, anti-IL-1 tocilizumab, and mycophenolate mofetil. And the rituximab being the highest, rituximab was used in 60% of the adult patients and 80% of the pediatric patients. 40% of the patients were also initiated on a ketogenic diet during admission, and 20% also received electroconvulsive therapy. 3 patients underwent bilateral oophorectomy. 2 pediatric patients underwent vagus nerve stimulation. 1 pediatric patient underwent DBS followed by right temporal lobectomy. And the sample size that they had was not sufficient enough to draw meaningful conclusion for correlational analysis. So the conclusion based on that was not published. Coming to discussion, the current study has found out some differences between adult and pediatric group that was observed. They have observed a sex theme, that is a female predominance in adult group, whereas in pediatric group it was not observed. And pre-existing medical conditions were more in adult group when compared to pediatric group. And pediatric group had better outcome. That is, they had 80% better good outcome compared to 60% poor outcome in adults. And this study also has results similar to previous studies. That is, 66% of the study population had cryptogenic NORS. That is, the cause remained unknown despite extensive workup. And this points to difference in treatment strategy and outcome in cryptogenic NORS patients. In Yanagida et al., he studied 83% of 83 patients of refractory status epilepticus and found out that cryptogenic NORS patients had more frequent prodromal fever, mechanical ventilatory support, dysymmetric diffusion or T2 flare intensities, less frequent involuntary movements, absent prodromal psychobehavioral alterations, and CSF OCB positivity. So he found out a score that is of use in identifying cryptogenic NORS patients early in the disease course and to modify our treatment strategies based on this score. And the components include the first feature is new onset refractory status epilepticus, highly resistant to conventional anti-seizure therapy. That is the definition of NORS. The second point is a previously healthy individual before the onset of status epilepticus, presence of prodromal fever of origin before the onset of status epilepticus, absence of prodromal psychobehavioral or memory alterations, absence of sustained orofacial limb dyskinesias, and symmetric diffusion of T2 flare hyperintensities, each of them given a point of 1. And the patients with higher score are more likely to turn out as cryptogenic NORS after evaluation. So they have to be considered as cryptogenic early in the disease course. Immunotherapy that was used in this study was also similar to the previous experience. That is, in this study also early immunotherapy, as we have already in majority. And the autoimmune causes of status epilepticus already found out by various case series and studies included antibodies to intracellular antigens like anti-GAD, DNR, SOX1, amphiphysin, MA, CV2. Whereas antibodies to surface antigens also there like LGA1, Casper, to NMDA, glycine receptor, AMPA receptor, GABA B, mGluR5, DPPX, GABA A receptor, neurexin 3 alpha. And in all of these cases where when it is antibody mediated, they have a potential for reversal with immunotherapy, which is already evidenced by various studies. And early treatment has shown a general rate of improved survival as studied by Bayan et al. In cryptogenic NORS patients, also initiation of immunotherapy early has shown significant benefits in previous studies as well, as in Kim et al. Regarding timing of immunotherapy, whether they have to be given early, the 21 patients were studied in this was an article published in Epileptic Disorders in 2022, where in 21 patients who were studied, 57% achieved good and long-term follow-up when they were given early immunotherapy. They have proposed early immunotherapy based on that. In antibody-mediated ones, especially anti-NMD and Casper encephalitis, is already proven that early immunotherapy, especially less than 40 days, is significantly related to a positive outcome. The overall functional outcome of the study, that is the mortality rate, was 3 out of 15, which was 20%, which is similar to prior studies as in Gasper et al., which ranged from 22 to 30%. And the poor outcome in adults and good outcome in pediatric population also reflects a difference in underlying pathology or a responsiveness in treatment, difference in responsiveness to treatment in pediatric and adult groups. Coming to the critical appraisal, the merits of the study, this is the NORS is a very rare disease having a very low incidence rate. So they have studied a very rare disease. They could find out 15 cases. And time timing of immunotherapy is a novel study. The demerits include the where patients were given from two centers that which had different guidelines for treatment as well as evaluation strategies. Coming to conclusion, this study highlights the critical importance of early diagnosis and prompt initiation of immunotherapy, especially in pediatric patients. New antibodies, we know already we have a case here. We have found out after extensive diagnostic workup also, we could not find out a specific cause. But it points out that in each year, new antibodies are being discovered. So we have to keep in mind that and give early immunotherapies in all indicated cases. And a prospective multi-center trial with randomization to different treatment protocols would generate the highest quality data. Thank you. Thank you. Ma'am, interleukins have been found to be increased in serum as well as CSF in patients with NORS. And the immune type of the interleukins are different from that seen in encephalitis. So, in the diagnostic consensus given also, they have included cytokines and interleukins in the diagnostic workup as well as anti-interleukins in the treatment. So 1 and 6 and anakinra and tocilizumab, especially when we are not able to find out an antibody in the early disease course itself, administration of tocilizumab or anti-IL-6 or anakinra can be beneficial there. What is about this? Whatever. Found out. Right. Yeah. Virus. Virus. Earlier, febrile infection related epilepsy. Children. Second. Infection. Or inflammation. Intravenous question. The interleukins have come up in a big way in case of the NORS uh, evaluation as well as treatment. And interleukins, whenever available, is available as a diagnostic. It can be done as a diagnostic uh, for diagnosis as well as when it comes to treatment. There are many antibodies that are not discovered yet. So most of the patients in cryptogenic nodes will have an etiology in future as some of the antibody mediated disorders. So all patients needed to be given immunotherapy, and in cases we should come forward with IL-6 therapy whenever patient is refractory to conventional immunotherapies, or rituximab whenever it is refractory to the rituximab. And uh, um, 2021. Immunotherapy. Expected. And as told, we have to give an ample time after the first line immunotherapy for the patient to respond uh, before being giving on to planning about a second line immunotherapies. Thank you.
Good morning, everyone. I'm Dr. Hrudya, and I'll be presenting the second journal for today. And the moderator for this session is Dr. Ram. This is a research article titled "A New Perspective on Drug-Resistant Epilepsy in Children with Focal Cortical Dysplasia Type 1: From Challenge to Favorable Outcome," authored by Splitkova et al. And published in Epilepsy, a journal, in December 2024. Focal cortical dysplasia is a malformation of cortical development which causes disruption of the cortical cytoarchia. The term was coined in 1971 when an unusual microscopic abnormality was reported in the lobectomy specimens of temporal lobe epilepsy patients. It comes under the broad heading of malformations of cortical development, which, apart from FCD, also involves polymicrogyria, subcortical band heterotopia, lissencephaly, schizencephaly, etc. Um, the first international consensus classification put forward by ILAE came in 2011. It classified FCD into three types. FCD type 1 had three subtypes, 1A being FCD with abnormal radial cortical lamination, 1B with tangential cortical lamination, 1C with abnormal both radial and tangential cortical lamination. FCD type 2 had two subtypes, 2A being with dysmorphic neurons and 2B with dysmorphic neurons and balloon cells. Type 3 is when FCD is associated with another principal lesion. Like for example, 3A is in association with hippocampal sclerosis, 3B with glial or glioneural tumors, 3C with when the lesion is adjacent to a vascular, and 3D is when it is when it is adjacent to a lesion like trauma, ischemic injury, or encephalitis. So this is what they have mentioned. 1A, this is the normal cortex. 1A is in when there is radial arrangement abnormalities, there will be, we can find a lot of micro columns in the cortex. This is FCD 1A. In 1B, there is tangential cortical lamination is disrupted. So this is the normal. This is the normal cortex, and both of these are abnormal. Here, there is thinning of cortex as well as the lamination is disrupted. Here, one L4 layer is altogether absent. This is the new consensus guidelines. Not much has changed, but the terminology in FCD subtypes has changed from FCD type 1A being abundant microcolumns and 1B is abnormal layering. For example, mild malformation of cortical mild malformation of cortical development with excessive heterotopic neurons, as well as mild MCD with oligodendroglial hyperplasia and epilepsy has been included. And also another category for when the abnormality of cortical organization remains ambiguous and histopathological findings are not compatible with type 1, 2, or 3 has also been included. So the clinical phenotype described as epilepsy types can be focal epilepsy or epileptic encephalopathies. They can also have epileptic spasms when the FCDs are located in the frontal lobes. Febrile seizures are also described, but only in a minority of patients. Status epilepticus and epilepsia partialis continua can also occur. Seizure semiology depends on the age at onset, location, and extent of the lesion. And one thing which is common to all FCDs is very less response to pharmacological treatment. And also they can have behavioral disturbances and cognitive impairment. This I've already mentioned. Coming to differentiation between these categories, we have already seen the histopathological differentiation. Genetics, a definitive genetic basis has been discovered only for FCD type 2, in which mTOR pathway genes are seen to be mutated, where it is non-specific for FCD type 1. Similarly, in neuroimaging also, FCD type 2 MRI abnormalities have been definitively described. For example, abnormal gyration patterns indicated by cortical dimple, cortical thickness changes, signal changes, both in the lesion and in the adjacent white matter and gray white matter blurring. These are all described in FCD type 2. Whereas MRI findings in FCD type 1 is more vague and many times MRI can also be negative in FCD type 1. These are the representative images of MRI changes in FCD, mostly in FCD type 2. Gyral thickening, blurring of gray-white matter differentiation. There can be focal hyperintensities and also a this is a transmantle sign. Hyperintensity extending from the cortex to the periventricular region. So when it comes to FCD type 1, the diagnosis itself is very challenging and many times a question mark, because the modalities available for differentiation, including EEG, imaging, and histopathology, are non-specific for FCD type 1. There is no distinctive scalp EEG findings for FCD type 1. Even when MRI using epilepsy protocol is employed. There is no MRI signature found for FCD type 1, and histopathologically also high inter-observer variability exists in diagnosing FCD type 1. Some studies have come up, for example, in this 2023 study, they have found out that they were able to differentiate between using a scalp EEG, intracranial EEG, they were able to differentiate between type 1 and type 2 FCD with 82% accuracy. For this, they looked into the indirectal epileptiform discharges. Also, when it comes to MRI differentiation, this 2016 study showed that there can be methods in differentiating type 1 and type 2 FCD. In type 1, they have found multilobar cortical thinning is more associated with the disease. So, with this, we have understood that a multi-layered diagnosis is required, including the clinical semiology, that is, clinical means the semiology of the seizure events, and also the neurodevelopmental problems or features found in the child, as well as EEG has to be employed, including the intracranial EEG, neuroimaging with MRI, as well as other advanced neuroimaging methods. Also, genetics can help in differentiation, and histopathology is the method by which we finally differentiate between type 1 and type 2. And like the diagnosis, treatment of FCD type 1 is also challenging, because despite the fact that histopathological pattern is not severe as in FCD type 2, and MRI can also be negative in FCD type 1, despite of these facts, the surgical outcome is very poor in FCD type 1. These studies give the data for poor surgical outcome. In this study, they have found out that only 21% of FCD type 1 patients had achieved seizure freedom, whereas 75% of FCD type 2 patients have achieved seizure freedom after surgery. In this, in the category including FCD type 1, only 50% patients were able to achieve seizure freedom after surgery. Here, the statistics is 46% only fell into the ILA class 1. Class 1 is when the patient has achieved complete seizure freedom after surgery. So with this background, we come to this study. The objectives of the study, it's a single center retrospective observational study. The objectives of the study was to expand the phenotypic spectrum of FCD type 1 to identify predictors of post-surgical outcomes. This included a cohort of pediatric patients, 31 patients with focal drug-resistant epilepsy who underwent resective or disconnective epilepsy surgery at Motol University Hospital in Prague between 2010 and January 2023. So, they took the data from electronic medical devices, and they have included, reanalyzed all the data of these 31 patients. The inclusion criteria were only two: histopathologically diagnosed as FCD type 1 according to ILA classification, and there was at least 1 year of post-surgical follow-up. So data collected were 2 time courses: duration from epilepsy onset to epilepsy surgery, duration from the first examination at the center to surgery, and neuropsychological assessment was done pre-surgically as well as 1 year after surgery using these tools according to the age of the child. Scalp EEG assessment was done for every patient. Background activity, sleep architecture was looked into, and the presence of sleep spindles, whether it is absent or if it is present, then whether it is symmetrical or asymmetrical. Local slowing, the extent and localization of IEDs, whether they are present, if present, regional, multi-regional, hemispheric, or whether they were generalized. And the presence of secondary bilateral synchrony, the presence of EEG status epilepticus, the extent and localization of ictal activity, whether it was not lateralized or if lateralized, it was regional, multi-regional, hemispheric. Intracranial EEG was not done for every child. It was done only when the patient had non-localizing findings on MRI, discordant findings on non-invasive examinations. The structural abnormality was adjacent to eloquent cortical areas. MRI with epilepsy protocol was employed. And in this, the positive findings considered were abnormal gyral pattern, increased signal in white matter or T2 flare, in the white matter in T2 flare, hypoplasia of white matter, blurring of gray-white differentiation, and cortical thickening. And further was classified into focal, lobar, multilobar, or hemispheric, and localization abnormalities was specified. FDG PET similarly was done for every patient, and the findings were classified into obvious hypometabolism, subtle or moderate hypometabolism, normal metabolism, and hypermetabolism. And it was compared with resection done after that, whether it was concordant with the resected volume, overlapping, partially overlapped, or discordant. Another method employed was SISCOM. It was also done only in selected cases. SISCOM, and the SIS stands for subtraction ictal spect. It is when the spect is taken during the interictal period as well as after inducing a electrographical seizure. So areas will be overlapped, and the epileptogenic zone will be found out after overlapping both ictal and interictal spect. Now, since the spect lacks visual, the spatial um, uh, localization with spect is a little bit difficult. So it was co-registered with MRI so that we can point out what was the epileptogenic zone. And after SISCOM, the findings were classified as focal, lobar, multilobar, or non-localized. And again, it was compared with resection to see whether it was concordant with resection or discordant. So the localization was done after employing all these methods, that is semiology, intracranial IEG when it was available, and also neuroimaging, MRI, FDG, PET, and SISCOM. The completeness of resection was computed as a proportion of MRI lesion volume included in the resection using label maps of the outlined lesion. In MRI negative or inclusive cases, instead of the MRI lesion, the completeness was determined by the proportion of intracranial EEG channels within seizure onset that were included in the resection. So the epileptogenic zone is not easy to localize because it is neither the lesion itself, it is not the ictal onset zone which produces the spikes during an ictal event. It is not the symptomatogenic zone which is responsible for the semiology of the seizure. It is not the irritative zone which gives IEDs during an interictal state, and it is not the functional deficit zone also, which is responsible for the functional deficit observed in the interictal period. So it is important to localize the epileptogenic zone using these methods so that we can go for a complete resection. The data regarding ASMs collected were a reduction in the number of ASMs, complete discontinuation of ASMs, whether or not could be achieved, and whether it was unchanged or modified without a significant reduction. So coming to the results, I'll be discussing the results after presenting the results as well. The clinical characterization, they have assessed patients on the basis of age at first seizure onset, whether or not developmental delay was present before epilepsy onset, the neurological findings, whether it was non-focal, normal, or focal, and also for the presence of focal seizures, whether there was focal seizure later generalized into bilateral tonic-clonic seizure, whether epileptic spasms were present, and the seizure frequency, whether it was daily, weekly, or monthly, number of anti-seizure medications used, seizure-free period, whether patient was able to achieve a seizure-free period before surgery. That is not that patient was gone into remission, but if patient was able to achieve a 3-month seizure-free period, that was considered as it is taken as a positive here, and the duration. Also, they have considered the findings of whether or not patient underwent intracranial EEG. S is for stereotactic EEG, and E is for ECOG. That is done during the surgery. And the extent of the lesion, surgery extent, which lobe was resected, intraoperative ECG, whether done or not, and outcome, classification of ILA outcome as the patients falling to after surgery, whether it was possible to reduce ASMs after surgery, and whether the drugs could be completely stopped or not, and pre-surgical as well as post-surgical IQ scores. So, summarizing all this, they've taken 17 females and 14 males. FCD subtype 87.1 percentage belong to FCD type 1A, whereas 12.9 percentage belong to FCD type 1C. 1B was not represented in this cohort. Family history of epilepsy, 3 patients had. Focal or non-focal neurological findings were present in 10 patients. Perinatal complications were present in 6 patients, that is 19.4% of patients. Developmental delay before epilepsy onset was seen in 16.1% of the cohort. Cognitive decline or regression during epilepsy was seen in a majority of patients, that is 80.6% patients. And median age at epilepsy onset was 4.2 years. Onset less than 3 years was seen in 15 patients, that is 48.4. Daily seizure was in 27, which is a very number when compared to the total number being 31. Median age at referral was 8 years. Median duration before referral was 2.3 years. Focal seizures were present in almost all patients, 27 patients. Epileptic spasms in 7 patients. Focal to bilateral tonic-clonic seizures were present in 51% of patients, and status epilepticus episodes were present only in 12.9% of the cohort. Drug resistance was seen in 100% of patients, and median number of ASMs tried is very high, that is 6. At the time of surgery, the median number was however 2. And so previously, Holthausen is the person who has done excessive research into the phenotypic spectrum of focal cortical dysplasia type 1. He has described the phenotype as onset of focal epilepsy in infancy or early childhood, localization usually in the posterior half of the cerebral cortex, no gender racial predilections, epilepsy becomes intractable and resistant to anti-seizure medication, and developmental delay is common. He has also described a well-defined entity called MUHCC, multilobar unilateral hypoplasia with severe epilepsy in children, which has early onset drug-resistant epilepsy, severe mental retardation, and characteristic electrophysiological and neuropathological findings. Comparing our phenotypic findings with these previously described features, age at onset was variable, but never less than 2 months of age. Frequency was mostly daily, but can be weekly or monthly also in a very minority of patients. Pre-surgical IQ ranged from 32 to 106, showing a wide developmental spectrum. And earlier epilepsy onset, we'll see that it is linked to lower pre-surgical IQ scores. 2 out of 31 had ADHD, and 3 out of 31 patients had autism spectrum disorder. One of them had Asperger's. Coming to the electrophysiological characterization. So background EEG was known in 17 patients, that is half of 54.8% of patients. And disrupted sleep architecture was seen in, again, almost half of the patients, 51.6%. Interictal EEG spikes, when present, were multi-regional and were noted in 20 individuals, with the maximum over the temporal or frontotemporal regions. Ictal EEG patterns were also multi-regional in 41.9% of patients, regional in 25.8%, generalized in 4 patients, and hemispheric in 3 patients, and not lateralized in, again, 9.7% of patients. Also, patients analyzing this data, they have found that patients with the disrupted sleep architecture had larger resection volumes than those with normal sleep architecture with a p-value of 0.05. patients with more extensive structural abnormality on MRI tended to have slow background activity. They also observed a trend of earlier epilepsy onset in patients with slow background activity compared to those with normal background activity. However, this was not statistically significant as the p-value was 0.13. Slow background EEG activity was due to lower pre-surgical IQ, the p-value of 0.04. Disrupted sleep architecture correlated with low pre-surgical IQ with a p-value of 0.04, and extensive epileptiform activity was observed even in those with low bar distribution and normal MRI findings. They concluded that there was no distinctive EEG feature in FCD type 1. Um, Earlier studies has shown again the same thing, that EEG and ECOG, including in-depth electrodes, are useful in localizing the epileptogenic zone, but the type of paroxysmal activity is not distinctive enough to differentiate type 1 from other lesions. Neuropsychological characterization. Median IQ score was 76. IQ scores more than 80 were observed in 42.6% of patients. A trend of larger resection volume in patients with lower pre-surgical IQ was observed, but this was not statistically significant. No, man, they haven't. Research. Radiological characterization. Neuroimaging correlation. FCD-related abnormalities were identified in 74.2% of cases in this cohort. This is in comparison with 60% in another study, which was another recent study. This and this shows that a higher number of patients with FCD type 1 can be negative with MRI alone. This also included, this 74.2% included 70.8% of patients who were classified as MRI negative before evaluation at this center. It shows utilization of specialized protocol is of value because more number of patients could be identified with employment of specialized protocol. Uh, 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 yes. So the distribution of MRI findings were multilobar or lobar with predominance in the temporal, frontal or insular lobes. FDG PET and Syscom imaging further localized the presumed epileptogenic zone in 6 out of 8 MRI negative patients. Coming to the surgery, 28 patients underwent resection surgeries and 3 out of 31 underwent hemispheric disconnection surgery. The extent of resection was focal in 8 patients, lobar in 10 patients, and multilobar in 10 patients. The median volume of resection was 38 centimeter cube. The median completeness of lesion resection as assessed with MRI was 77%. The completeness of resection as assessed with intracranial EEG was 88.2%. Complete hemispheric disconnection was achieved in all 3 patients. All lesions and resection extents were manually outlined in the preoperative MRI using 3D slicer software and exported to binary label maps with voxels belonging to lesion and also resection, lesion or resected area and the background. The lesion or resection volumes were computed as the number of voxels multiplied by the volume of an individual voxel. I'll demonstrate this with an example. Patient number 21 is a 14-year-old male child with seizure onset at 10 years, normal neurological examination, having focal as well as focal with the secondary generalization seizures, daily seizure frequency, and on 4 anti-seizure medication. They utilized stereo EEG as well as electrocorticogram for this patient, and surgical extent was lobar and that of temporal lobe. Outcome was seizure freedom on no and they were able to completely stop the anti-seizure medications after surgery. This patient had a normal MRI. Um, the Syscom image was showing lateralizing, but lateralizing to the right hemisphere, but it was non-localizing. Then the FTG PET was done with additional post-processing, which showed mild hypometabolism on the base of the temporal lobe. Then targeted stereo EEG exploration was done by employ electrodes in the frontal, insular, temporal, and Rolandic opercular areas. By this, they confirmed that the seizure onset zone but the interictal epileptic form discharges were widespread. So during the time of surgery, they also used the electrocorticogram also. And using the electrocorticogram, initial plan was the little onset zone was localized to this red area. And during the surgery, using the ECOG, the resection volume was extended to involve this orange area as well. And with this resection, patient was able to achieve complete seizure freedom. Another example is that of patient 6 is a 3-year-old female child with seizure onset from 3 months of age with focal and non-focal abnormal neurological examination. She had focal seizures and spasms with daily seizure frequency even on anti-seizure medication. For this patient, on the MRI imaging, the lesion with the gray white matter blurring was seen in the frontal and the temporal lobes, whereas FDG PET showed a more extensive involvement of the hemisphere. And because of that, they decided to go forward with left hemispherotomy disconnection surgery. With extensive evaluation, the surgical outcomes in this study was found to be better than the previous studies, with 22 patients achieving complete seizure freedom, falling into ILAE class 1, 2 patients falling into ILAE class 3, 4 patients achieving ILAE class 4, and 3 patients had class 5. This is the ILAE classification. Class 1A is complete seizure freedom since ASMs were reduced in 21 patients. Complete withdrawal was 6 individuals. But there was no improvement in IQ, no correlation between post-surgical increase or decrease in IQ and seizure outcomes also. Outcome analysis. Seizure outcome was similar in MRI positive as well as MRI negative group. Though numerically, MRI negative patients had a trend of achieving more seizure freedom after surgery, but this was not statistically significant, and the seizure outcome was therefore concluded as similar in both groups. ASMs, they were able to reduce ASMs in 67.7% of patients. Patients with regional ictal EEG patterns had a better chance of reducing anti-seizure medication, and this IQ scores had no correlate with the completeness of seizure resection. So, in order to predict seizure freedom, they employed a statistical tool called generalized linear model, stepwise generalized linear model, and they analyzed 9 variables for the statistics. And out of these 9 variables, which included the completeness of resection and those factors as well. But these are the 5 variables that emerged as statistically significant and contributing to seizure freedom. The earlier epilepsy onset, negative means it has a positive impact on the seizure freedom. Earlier epilepsy onset, shorter epilepsy duration, less extensive MRI abnormalities, clearly visible PET abnormalities, and when an intracranial EEG was performed, it increases the chance of achieving seizure freedom. And altogether, the p-value was less than 0.003. So, phenotypic findings from this study, broad spectrum of clinical features with IQ ranging from 32 to 106. EEG variability was there, predominantly multi-regional and often bilateral epileptiform activity with slow background and disrupted sleep architecture with a correlation with low IQ scores. Neuroimaging, 74.2% showed specific changes in MRI itself and MRI findings using advanced protocols. Almost a quarter remained MRI negative. Multimodal localization, employing other advanced methods like PET and ictal SPECT co-registered with MRI Cisco. With usage of that, we are able to localize dysplastic cortex in MRI negative cases as well. So we have concluded from the study, it is concluded that phenotypic heterogeneity in FCD type 1 is greater than previously described, and a possibility that a multi-layered pre-surgical workup utilizing advanced imaging as well as electrographical means to precisely localize epileptogenic zone may result in a more favorable outcome of epilepsy surgery in FCD type 1, comparable even to the outcomes of FCD type 2. So, limitations of the study was everything was based on the histopathological diagnosis, but the final diagnosis itself, there's a reported high significant inter-observer variability among expert neuropathologists also. And there is no genetic correlation with FCD type 1 diagnosis, which is identified yet. Also, they have considered a very small sample size, and also it is a single center study. So extrapolation of the derived data to a larger population of FCD type 1 may be difficult. And they have combined the data of patients who had underwent hemispherotomy along with the patients who had underwent a resection. Patients with hemispherotomy, since we are disconnecting the whole of the hemisphere, they are more likely to achieve complete seizure freedom. It's the largest single center cohort study of FCD type 1. It is clinically because most of the previous studies are radiology focused reviews. It emphasizes EEG, cognition, neurodevelopment, and multimodal diagnostics. Highlights importance of multi-layered and thorough pre-surgical workup and its role in obtaining a favorable surgical outcome. Patient-centered. It links phenotypes to outcomes, informing both prognosis and personalized treatment. FCD type 2.
As compared to mention that this should have often very 45% that mass. That should have long. This employment of not practice not really newer, but more type of modalities where you can overlay this investigations like that. This is from on the MRI. Some of the reference that you could say it should be really difficult case, it should be very very injection of the data and that makes up the data. And you overlay that on a suspected MRI is really in the position of this particular, and it will also tell you where to place the evidence. In those cases when your margins are very poorly defined, which is a common problem with FCT kind of work, where you have to place the evidence when you want to interpret a leaky vanish, it's often guided by this investigations. Suppose these investigations come back negative, the placing evidence also will be and you have to rely on monarchies like methods, etc. Which has not been studied as part of this. Also, as you said, I believe those patients which have developmental comorbidities, it's probably a genetic basis for this, which has not been established either by studies in the blood of these patients or from the cervical tissue of these. Both of these are not really shown correlations. Wanted to find the right group. But it seems hopeful a lot of patients who are saying one apparent people should keep some focus around our the patients that the presence estimated and try to generate this information using other all these modalities of that.
We have come to the end of the session. Thank you, everyone.